Good afternoon, everyone, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Understanding Childhood Trauma, Outcomes and Interventions, presented by Dr. Amanda Elliott. My name is Kathy Dixon, and I'll be moderating the session today. I'll cover a couple of housekeeping announcements before we get started. The webinar will be recorded and made available for viewing on our YouTube channel. The link will be shared in the follow-up email after the session. Following the presentation, we'll have time for questions. Please use the Q&A box in the webinar toolbar to submit your questions, and we'll cover as many questions as time allows. Instructions for how to claim credit will be uploaded to the chat, and I will also send this in the follow-up email after the session. So without further delay, it's my pleasure to introduce Dr. Amanda Elliott. Dr. Elliott is a board-certified child and adolescent psychiatrist who is a clinical associate professor in the Department of Psychiatry at the University of Iowa. She has been providing care to youth in Iowa since 2014 in a variety of settings, including the inpatient hospital unit, outpatient clinics, and telemedicine school-based clinics. She currently shares time between University of Iowa Healthcare and the Scanlan Center for School Mental Health Clinic. In addition to patient care, she is passionate about education and advocacy about the importance of supporting youth mental health. So welcome, Dr. Elliott.
Thank you, Coffee, for the kind introduction. Good afternoon, everybody. I'm excited to be here. So like Coffee said, my talk today is on understanding childhood trauma, outcomes, and interventions. And my slides won't advance, of course not. There we go. Disclosures for today. Neither myself nor the directors or planners have any relevant financial relationships with commercial interests that we need to disclose today. As most talks that you'll see for child psychiatry, there's very limited research to support full FDA approval for many psychiatric medications for youth. So this talk will include discussion of off-label use of medications. Our goals for today are to recognize experiences that children may encounter in their lives that might be traumatic, outline common symptoms related to mental health disorders that might occur as a result of trauma, and evaluate treatment interventions for youth who may have experienced a traumatic event in their life. So why does this matter? Many people might think Iowa kind of pretty rural community, not a lot of trauma seen here. But what studies have shown us is there is a lot of trauma that youth experience. Looking at data from Iowa 3.6 or ACEs, this looks at adult data that reflects upon their childhood. So 25%, so a quarter of Iowa adults report they experienced 3 or more adverse childhood experiences when they were children. And 2/3 of Iowan adults report at least one adverse childhood event when they were younger. I specified Region 6 because many of my talks are given in Eastern Iowa, but out here, we have the highest percentage of ACEs in the state, where nearly 20% of adults have experienced 4 or more ACEs. We don't have data reflecting much on the past 5 years yet, particularly what children have experienced, but we're expecting that ACE data will be even higher for this generation of youth. What else is important about this? So 21% of students who had done the Iowa Youth Survey back in 2018 endorsed that they had experienced thoughts of suicide at some time in the recent past. Almost 15% of students don't feel safe at school, particularly if they're of minority backgrounds, and almost 60% are fearful of anti-immigrant sentiments. 15% of students report someone at home with a drug or alcohol problem, which is one of the risk factors associated with their own mental health concerns later on. And 10% of students disagreed with the statement that I have a happy home. So why does that matter? For youth with 4 or more ACEs, they're much more likely to experience academic failures. They're much more likely to have attendance issues, and they're almost 7 times more likely to have problem behaviors in school. Not only is that a concern for their academics, but that certainly affects our colleagues in psychiatry and pediatrics as well. Because if they're having attendance issues, parents might be calling for excuses. If they're having challenging behaviors, they're probably going to call you before they have an opportunity to see someone like me. So what sorts of things count as trauma or ACEs? It's really dependent on which literature you're looking at. On the ACE level, things are much broader. Whereas if we dial down to the level of DSM, it's much more narrow. So a lot of the common types of trauma include abuse, which can be physical, sexual, or emotional, neglect, a family member with mental illness or substance abuse, divorce, domestic violence, an incarcerated parent, homelessness, food insecurity, or death of a loved one. Just looking at that list, you can see that many might overlap. If a parent has had substance use issues and is incarcerated, they might have financial stressors at home. So many times it's pretty easy to tick up that ACE count. And things in the community can also be traumas. So in Iowa, we have our share of natural disasters like tornadoes and derecho. Things like community violence, community poverty, and school violence all can impact youth as well. On the school angle, things like bullying and school shootings are two of the more common violences that they experience. When we look at DSM criteria, it requires exposure to actual or threatened death, serious injury, or sexual violence. They either experience it themselves, they witness it happening, or they learn about family members in danger. This is very, very narrow, in my opinion. And I am often comfortable diagnosing some of the trauma-related disorders that experience or that occurred more broadly than this narrow definition, because clearly they experience something and they're having the symptoms. So I'm willing to treat them as such. However, it's really important to remember that what someone experiences as traumatic, someone else might not. Some youth that have survived a tornado might be terrified and have future ongoing trauma symptoms, while others thought it was a cool adventure. How the adults in their life responded in that moment and how they're modeling a response often plays a role. So if something scary is going on and the adult is staying calm, cool, collected, and treats it like an adventure, the kids are more likely to experience it in that light. Loss of a pet. For some kids, that's a huge loss, and it's something they'll talk about losing their first pet through their entire lifetime. Others, oftentimes in Iowa, kids that live on farms and see a lot of that natural life cycle for animals think it's a normal process and no big deal. Assaults also, well, we might assume everybody would find traumatic, others might not find it so traumatic. So when we're interacting with folks who have experienced trauma and are telling their story, it's important to let them tell their story and how it's impacting them, rather than us assuming or putting our thoughts on how serious it is onto them. So we don't want to invalidate someone's experience of trauma, whether it's their dog passing away or bullying at school, saying that that's less significant than an assault. Similarly, we don't want to assume that someone who has an assault history has significant trauma symptoms that they're hiding or not telling us. Letting them share what they're experiencing is really important. So trauma certainly has an impact on the brain and its development. Even if it occurs as an adult, there are chemical changes in the brain related to your stress hormones, cortisol levels, things like that. When we look at this in a developing brain, it has even more impact for lifelong stress hormone responses. Repetitive trauma tends to cause more severe symptoms for most people. And again, similar to the last slide, every human's response to trauma and interventions can be different. If anyone wants to learn more about some of those chemical changes and sequela, The Body Keeps Score is a really great book. So what about the mental health risks associated with trauma? So trauma is kind of that central feature. The most common ones people think about might be post-traumatic stress disorder or PTSD, as well as acute stress disorders. Other things that might occur are adjustment disorders and prolonged grief disorder. And then things that might happen more commonly in our younger children are reactive attachment disorder and disinhibited social engagement disorder. This is certainly not a limited panel. Certainly trauma when you're young might lead to other types of anxiety disorders later down the road, or depressive disorders later down the road. That said, in this talk, since it's somewhat limited on time, we're going to focus more on these trauma-specific diagnoses. So looking first at those younger children, the two trauma-related disorders that they might experience mostly occur with children who've experienced neglect of their basic needs, which includes affection, frequent changes in their primary caregivers, and when we see children who are adopted to the United States that were raised in institutions such as orphanages overseas. What reactive attachment disorder looks like is a pattern of inhibition and withdrawal. These are youth, even as babies, all the way through teenagers, that might not seek out comfort. They might not share a lot with people. They tend to have minimal socialization with others, so tend to have fewer friends, limited positive mood expression, and unexpected irritability, sadness, and fear that might pop up in their day-to-day life. It can be very hard to engage in relationships with folks whose early attachment was affected. They didn't learn they could trust humans as a baby. People didn't respond in a healthy way when they were crying, so that I can rely on adults, I can rely on other people. Those signals never really processed correctly in their brain. As they grow up, even if they have loving parents, great teachers, great therapists, they can be really hard to engage in a trusting relationship. It really takes a lot to prove that you can earn their trust. So a lot of patience, a lot of baby steps, consistency, and time. A lot of times it's not having expectations of what that relationship's going to look like, which for adoptive parents who are trying to improve the life of a baby or a young child can be really hard to manage their own emotions and expectations when their child has reactive attachment disorder. The opposite side of that, which is interesting that it occurs in children with the same type of experiences, neglect of their basic needs, frequent changes in caregivers, raised in overseas institutions such as orphanages, is that disinhibited social engagement disorder. These kiddos do not hesitate to approach strangers. Rather than not learning that adults are trustworthy, they really didn't learn much about appropriate social relationships when they were younger. How to trust, how not to trust, who might be dangerous, those sorts of things. So they will approach strangers. If you have them at the mall, you might be shopping here, and the next thing you know, they're out in the walkway talking to somebody sitting on a bench. Tend to be overly familiar with people that they meet, might tell them their entire life story. This can happen both with young kids, where they're telling strangers details about their life, or some of the teenagers we see that don't have great understanding, that are sharing extra information like their home address on social media. Certainly that can come from other causes as well, but youth who had that disinhibited social engagement disorder would be higher risk for that sort of thing as well. Also developmentally, kind of those stages where kids are often kind of checking over their shoulder for their caregiver to see if this is a safe setting, if this is something I should trust, if this is something I should take caution with. These kiddos don't do that. Because of all of these things, these youth tend to be at higher risk of victimization, be it kidnapping, be it abuse or trafficking. So then the directly trauma-related disorders, this is where I get a little less picky about that required exposure to an actual threatened death, serious injury, or sexual violence. All of the symptoms for both acute stress disorder and post-traumatic stress disorder are the same. It just depends on the time context when it's being experienced. So in the first, after 3 days up to 1 month after a traumatic event occurs, that's called an acute stress disorder. After 1 month, if those symptoms are persisting, that's when it transitions to post-traumatic stress disorder. There are 4 global symptom clusters with post-traumatic stress disorder. The first being re-experiencing, which most often comes in the distressing memories, nightmares, and flashbacks. Avoidance is really common. So people tend to avoid memories, places, people, objects, smells that remind them of the traumatic event. This one can often be difficult to get at because, let's say they've been removed by HHS due to abuse that happened in the home. We might not have a good history of what had happened beforehand, and their avoidance might not be of the situation, the people, the places. Their avoidance might be talking about what happened. So sometimes getting at that PTSD diagnosis when you don't fully know the trauma can be a challenge because of that avoidance symptom. The third cluster are negative cognitions. So a lot of things related to low self-esteem, blaming themselves for the trauma, a new perspective that the world is a bad place and I can't trust anyone, persisting low moods, and a tendency to withdraw from activities and people. And then the final cluster are mood and behavioral arousal or reactivity. So this is your startle response, your hypervigilance, feeling jumpy, difficult concentrating at school or at work because your brain's always kind of on the lookout for the next dangerous thing. What about some of those, what most people would consider more mild trauma-related disorders? So an adjustment disorder occurs up to 3 months after a stressor. And the distress experienced by the individual is greater than expected for the situation or the cultural norm. So many things that are common for youth, moving, parental separation, breakups in our teenagers, failing exams, injury, surgery, illnesses that have kind of changed how their day-to-day life functions. Some kids just roll with the punches, and at school or in your primary care office, you might not notice any difference. For some kids in those situations, life kind of goes off the tracks. Behaviors increase, mood decreases, relationships with people are impacted. So it really can have a big impact, even though kind of that trauma might seem small to other people. And kind of, like I had mentioned, can occur with impairing their function at school, work, in their family, or in their community. So here we have a gap in time, which is one of my other concerns with how DSM explains things. There's this gap between 3 months and 6 months. So let's say you had a grandparent pass away. And so for that first 3 months, it can be called an adjustment disorder if you're experiencing persisting low moods. However, between 3 and 6 months, there's no great category to catch that. But certainly prolonged grief disorder happens to a lot of young people and a lot of adults. So there's an intense longing for that person, overly focused thoughts on that person. So they might be really distracted at school, distracted from their chores because they're spending so much time thinking about their loved one that they lost. Some people lose their self-identity and have difficulty in relationships because they had identified who they were as a person in relationship to that person they lost. So now they're not so sure who they are anymore. You might have disbelief of death, particularly in younger kids. If they had a relationship, they might still kind of come back to the when am I going to see grandma again kind of questions. And there's that developmental standpoint, but for some kids, it could also be prolonged grief. Some people might avoid reminders of the person. So if there are pictures up around the house, there are some kids that'll go down and knock them over because they don't want that reminder every day. They might experience intense emotional pains and feelings of loneliness that other people might have a hard time explaining why this loss is so hard for them. And they might feel like their life is meaningless without this person around anymore. So those are the basics of the trauma-related disorders and kind of the DSM criteria that gets you there. So, okay, those exist. We know traumas exist. We know those mental health diagnoses exist. Now what? How can you best support a youth following a traumatic event? So unfortunately, there's no right thing to say or a perfect answer that's going to bring someone comfort. Kids need to feel heard, know that people care, and know that they're not alone. That said, there are 2 things at least that are probably not great things to say. So telling someone to cheer up kind of invalidates their experience. Tells them you shouldn't be feeling sad, you shouldn't be feeling angry about whatever this traumatic event happens, whereas it's important for them to have that opportunity to feel their feelings, sometimes talk about their feelings, hopefully not act out their feelings, but not saying things that are going to make them feel that you don't understand or you don't care how they feel. The other thing that's important not to do is minimize. So let's say someone experienced a house fire. And, well, at least you all survived. For the kid that lost all of their sports equipment or their pictures or something in the house that was really important to them, you saying at least your family's still alive doesn't make them feel you understand the loss that they experienced. I'll give you more practical what now in a few slides. But I also wanted to let you guys know I know a lot of folks will use a PHQ or a GAD-7 in clinic. There is a brief screener for primary care settings that's a 6-question self-report that asks about, have you experienced the trauma? And then has follow-up questions on those symptom clusters. It's called the PC-PTSD-5, and that's related to DSM-5, not that there's 5 questions. The number differential between 6 questions and 5 in the title initially confused me. So what about behavior changes? What might we expect? So sometimes we'll see new concerns arise or previous challenges get worse. So academics will often decline for our older kids following a traumatic or disruptive event in their life. Concentration at school might be really hard. If we're thinking about a parent or grandparent who's sick in the hospital or something that we've lost, or the trauma that we experienced kind of replaying over and over in our head, it's really hard to focus on algebra. A lot of kids might be overly sleepy. It's important to ask what sleep has been like. Are they having trouble falling asleep, staying asleep, waking up too early? Are they having nightmares? Certainly, there are things we can do, whether it's in primary care or psychiatry, to provide resources on good sleep hygiene. Maybe evaluating, are there reasons they don't feel they can sleep at home? Do they not feel safe at home? Is it a situation where parents separated, or one parent is incarcerated and the other parent is working shift work? So they're at work with the parent, or they're in a car, or when the parent gets off work, it's disrupting when they get home and have an opportunity to go to bed. Sometimes there are social reasons that might be impacting getting enough sleep. And certainly medical causes. It's always important not to view stress or mental health symptoms in a vacuum. Maybe as a result of their trauma, they've gained weight and now they're experiencing more sleep apnea. Maybe they've developed thyroid condition or diabetes, things like that. So making sure kind of we don't get too narrow of a focus on the trauma that's experienced, and make sure we're keeping tabs on their medical conditions as well. Some youth might resort to substance use, so that's something that's important to screen for as well. Disruptive behaviors, I shouldn't say commonly occur, but it's not a surprise when they occur to youth who have experienced trauma. And this can come from many different places. So kids might be seeking attention or connection with the adults in their life. If the adults are so focused on funeral planning or insurance from a house fire or tornado, or their own relationship to the trauma that occurred to their child, it might be hard for them to give enough attention. So the child might feel like they have to act out to get that attention or to have that good connection time with their adults. Kids certainly might be irritable. Most of us as adults are irritable when we've had a trauma or stressor in our life, and we usually have more coping skills than kids do. So that irritability is not unexpected. Like I mentioned on the last line, poor sleep. Most people are more irritable, more grouchy, and less well-behaved when they're not sleeping well, and often less flexible. So the changes in their schedule, other minor traumas or other stressors that come up, they might respond more poorly to each time something new comes up. And then in primary care, you guys will probably be the one that get the first sets of complaints about regression of behaviors, regression of developmental milestones. This is probably not a entire list, but things that come to mind for me are regression of speech skills, regression of kids who were previously toilet trained that now are having accidents, regressions in sleep, regressions in behavior or maturity, regressions and loss of academic skills. All of those things are not surprising if they happen after a trauma. What else might present to your office? Physical complaints. A lot of times kids who are sad or anxious find it easier to say they have an upset stomach or a headache or body aches rather than telling their parent they feel sad or that they feel anxious. So let's get more specific about what to do. Some of the clinical practices that could be helpful. So being as predictable as possible. When things have happened unexpectedly that cause stress for youth, they really worry about what else is going to happen unexpectedly. So as many familiar things as you can have in place for the kids that are coming to clinic can really help decrease that. I know a lot of clinics, whether it's staff turnover or schedules, might have multiple nurses, MAs, things like that that interact with the patient or family during their visit. If it's possible to try to keep a schedule or the same staff that that child knows on a consistent basis, they're probably going to feel more comfortable and safe seeing you. Encouraging body autonomy to the best degree possible. So are there ways to gown more conservatively? Considering what are required exams. I have an example. So my son does not have a trauma history, but at one of his well child checks, he kind of balked at having his genital exam done. Our family physician responded amazingly, unflappingly, accepted that no. And then after the exam was done, after clothes were back on, he explained why that is important to have those exams done, and that hopefully the next time he comes to an appointment, he'd be comfortable having that exam. It was really great that he had that conversation about education as well as next steps so that, again, in the future, it's not going to be a surprise. permission to refuse when possible. Certainly there are going to be times where an exam or a test is medically necessary and there's no avoiding it. But giving a child some control of their life when they haven't had control over things can be really strengthening and a good moment for them. Giving as many approved choices. So don't ask, do you want to get a shot today? Most kids, especially kids who've had trauma, are going to tell you no. So would you rather have the shot in your arm or your leg? Would you like to use the buzzy or freeze spray? Or would you like us to count down, surprise you? Would you like mom to hold your hand, or would you like to sit on the table by yourself? So kind of the choice of whether or not they're going to do the activity might not be there, but are there other things to give them some choice, some autonomy, some control that you can't offer to them? Also avoiding surprises. So advance notice of potentially scary things. So I know other visits, kind of throw my son under the bus. He does not like shots. So we talk about before we go in for a well-child check, gonna get these shots today. Oftentimes he won't get them, but we then circle back and tell them, okay, we're going to schedule another visit and we're going to come in and get this shot. So kind of giving as much advance notice to potentially scary things. For some kids, it might be shots. For some kids, it might be a full physical. For some kids, they might have to have procedures or tests done that are scary. An appropriate level of education. Certainly, you don't need to go through an entire surgery step by step for a child. But if there are things that's helpful for them to know to prepare for a shot, a procedure, a surgery, to decrease anxiety in the moment, I think that would be really helpful. Another thing that's helpful is to consider our own communication styles. Kids with trauma are extremely observant about their environment, and they can be very sensitive to what they view or they hear as a dismissive or disappointed look on your face, tone of voice. A lot of kids might come away from something thinking, my doctor doesn't like me. My doctor's mad at me because they came in with a complaint based on how they view your reaction. So thinking about a child and trying to present kind of neutral, positive as much as possible. A lot of kids with trauma are also sensitive to loud volumes. So things like your volume might be louder than they expect. They might consider that yelling where no one else would. Similarly, in a setting where you might have multiple patients being seen at the same time, if you've got a young child getting shots in the room next door and they're screaming, that might cause distress for this kiddo as well. I don't expect any of you to become psychiatrists or to do full education sessions on topics, but there are a couple of things that might be helpful that you could do in a primary care visit without a lot of time added to a visit. So sleep hygiene is something that's really important for all of our kids, but especially if they've had trauma and are having sleep disruptions. So figuring out how to create a calm, safe environment in the home, whether it's a room, whether it's the type of night lights, whether it's the blankets or stuffed animals, knowing how they can check in appropriately, things like that. Having a bedtime routine. When are we going to have dinner? When are we going to take our bath or shower? When are we going to read our books? When is bedtime? And keeping that as similar every night as possible. Emphasizing no screens in the bedroom. And I put a website on here that has a bunch of handouts that are really helpful for sleep hygiene for toddlers all the way through teenagers. One of the things I'm going to do after the talk is send Coffee a list of my resources and references so that you guys will have access to those. Another thing that shouldn't take a lot of time in a clinic visit is teaching some basic emotion regulation and breathing exercises. One of the easy ways to do that is with shape breathing. So for example, a square kind of, and some kids will even like trace it on their hands. So kind of as they go across the top, they'd inhale for 4 and then exhale for 4, inhale for 4, exhale for 4 as they go around a square. Or others will do a triangle, kind of inhale for 4, hold for 4, exhale for 4. This worksheet has probably 5 or 6 different shapes. On some of the kids that I've worked with on the inpatient unit will do infinity breathing because they have a pattern that they do as they trace the infinity symbol on their hand. And there's also that sensory component in addition to the breathing exercise that helps them to calm down. So what about interventions? What can we do? What is the evidence for therapies and medication? So there are three types of therapy that have some evidence basis for working with youth who have been traumatized. So there's an evidence base for cognitive behavior therapy. There's even more trauma-focused CBT. There is evidence for EMDR, or eye movement desensitization and reprocessing. There's also evidence for child-parent psychotherapy. Some folks or places call that CPP. I'm not as familiar with general CPP resources in Iowa, but two that I am more familiar with that are similar in their goals are parent-child interaction therapy and circle of security. What they found in most of the research studies is that in the acute phase, most people aren't showing immediate relief. Most kids don't show immediate relief in their symptoms. But when they're involved in therapy early, their long-term PTSD symptoms tend to be better. We'll briefly look at these more specifically, again, because I'm not expecting any of you on the call to become a therapist, but just to know what your patients might be doing if they say they're doing one of these. So cognitive behavior therapy often is working on our thoughts and how our thoughts react with our behaviors, and looking at the relationships and how maybe we can challenge things. There's also the specific trauma-focused CBT, where you learn a lot of emotion regulation skills and then some of those cognitive challenging skills, and then apply those to the trauma narrative that you've experienced. One study that I found they did in Norway included kids as young as 6 in the CBT group. And not only did they have notable improvements in their core PTSD symptoms, they also had significant decreases in the disturbances of self-regulation. You might notice that's not a symptom cluster I referred to in PTSD. There is a concept called complex PTSD that's used in ICD and more often discussed in European studies than American studies. But you look at these things: emotion dysregulation, negative self-concept, disturbance in relationships. Those things also improve for the kids who did cognitive behavior therapy. This is probably one of my favorites if I had to pick one, because it tends to be the most consistent in what youth experience because it's very manualized. Another thing I love is that they have a website that can help you or a family find a trauma-focused CBT trained therapist. So on that website, you can choose the state that you're from, and then it'll list the folks that are certified in trauma-focused CBT. EMDR stands for the eye movement desensitization and reprocessing. This is mostly supported by studies that have been extrapolated from adults. There is one small study I found in Europe that showed a significant decline in PTSD symptoms, but due to the small size of the study, they felt replication would be important, and I haven't found any follow-up studies on that yet. Very briefly, while they're in therapy, they're accessing their memories about trauma, and the therapist is using different strategies for eye movements and giving them directions to help retrain the connections their brain has related to the traumatic memories and distress. Outcomes of the study, anyway, show a decrease in negative emotion and a decrease in vivid images such as flashbacks. With some of the children I've worked with, experiences have been widely varied as far as what their therapist has been doing when they have EMDR. So it's one that I haven't recommended quite as heavily for most of my patients. At the same time, I hear plenty of folks that find it very helpful. So Coffee had sent me some of the early questions that you guys had sent in, and it sounds like a lot of folks might work with the early childhood ages and had questions about preschool. There are a grand total of 2 studies in a large Cochrane review of therapies for PTSD and trauma-related illnesses that looked at that 3 to 6 age group. The first was a CBT-focused program that had 12 weekly sessions that worked with both the kids and the parents. So working one-on-one with the child, they did trainings on assertiveness, addressing their feelings about the perpetrator, addressing their behavior, and addressing anger. There was also work that the parent did regarding their belief about the abuse, their feelings about the perpetrator, their own fear or anger. If they have their own personal trauma history, that's a lot of baggage that they're going to be bringing when they're trying to help their child cope. Maybe education on some of the legal issues or how to approach things or how to support their child for a deposition. certainly emotional support, and often behavior management, because in those youngest kids, it's usually going to be disruptive behaviors that you see most commonly. Second study was specifically that child-parent psychotherapy, focusing on those maladaptive behaviors. This study is probably not going to be the most likely replicated with what happens in real life, because these child and parent combos did 60-minute sessions for 50 weeks. I don't know a lot of families that have the time or dedication unless they are that desperate for the symptoms they're seeing to get help, but certainly some families might. A lot of CPP is play-based, so you might see things such as a dollhouse that has certain toys in it that might help bring out the trauma narrative as the kid is playing. They might relive situations. So, for example, playing out the scene that happened in trauma, but then the parent acting a different response than what happened to the child in the initial event that occurred. Things that I'm more familiar with around here, parent-child interaction therapy is one that addresses a lot of challenging behaviors in kids preschool through elementary school. It works with parents and kids as far as their communication, relationship skills, and how to support the parents in giving the children good directions to help see improvements in behavior. There's a great website that lists all of the providers in Iowa. So I like that one a lot. Circle of Security is often thought of as a therapy program for mothers with borderline personality disorder, which has often come from a period of their own trauma. So this is helping the parents think about their own trauma, their own behaviors, and how they might change what they're doing to better support their children. Vast, gross simplification, but it can be really powerful for parents, particularly mothers. Again, they have a website. I cannot validate that one. The trauma-focused CBT and the PCIT I use on a regular basis to give families those links. I have not given this one to families before, but it exists, so I wanted to give it to you. Well, what now? There are no FDA-approved medications for pediatric PTSD. Do we stop here and call it a day? Do we proceed cautiously? Probably better to proceed cautiously. So what role is there for medications in PTSD? So antidepressants largely address the anxiety-related symptoms. However, in 2 open-label studies, they did show some benefit to all of the symptom clusters. So those 2 open-label studies that were done for adolescents with PTSD were citalopram and fluoxetine. Citalopram at present does not carry any FDA indications for youth, but we certainly still use it in cases of depression, anxiety, and PTSD. Fluoxetine also has an open label study that showed improvement in PTSD symptoms. In theory, the FDA indication is primarily for depression in youth over ages 8. But again, we tend to use it for more diagnoses than just depression. There was one randomized control trial that looked at sertraline versus sertraline combined with CBT versus CBT alone. So in this study, the medication arm did not show statistically significant improvements compared to the active treatment arms. Well, we know CBT is pretty darn effective. So even though it didn't separate, we still think that as an SSRI, sertraline is a good medicine for folks with PTSD. Similarly, most of our antidepressant studies, the placebo arms have such high values that we often don't even see our antidepressants that helpful for depression. So just to be clear, kind of the only FDA-approved SSRIs for youth are fluoxetine, escitalopram, and sertraline. That said, there's good adult data for those medications for PTSD. We have a fair amount of safety data with open label studies, case reports, things like that, that we, and I'll say I particularly am comfortable using citalopram, escitalopram, fluoxetine, and sertraline in youth. One caveat I will have for youth that are highly reactive, that have a lot of those emotional reactivity symptoms, the activation from fluoxetine can make those symptoms worse. So those are patients that I'm going to be more likely to use escitalopram or sertraline for. What about alpha agonists? So again, there's a study out there for youth 3 to 6 years old that used clonidine and found good outcomes in decreasing aggression, impulsive behavior, emotional outbursts, insomnia, and nightmares. None of that really surprises me since we use clonidine for ADHD to decrease aggression, impulsivity, emotional outbursts, and insomnia. So it's good to see that that can help even in an absence of an ADHD situation. The guanfacine study found primarily a decrease in nightmares, but clinically, I see guanfacine and clonidine having very similar decreases in behaviors for ADHD. So I would expect it to have similar decreases in the aggression, impulsivity, and emotional outbursts that we're seeing in clonidine. Prazosin is a medicine we use often for adults with nightmares and PTSD. There are some studies that support its use for decrease in nightmares in adolescents, not currently data for use in children. And there was one case report of 3 youth treated with risperidone that showed a decrease in aggressive behaviors and emotional outbursts. I very intentionally made that text very small. That is not something that would be my go-to if I were working with kids, especially young kids that are coming in with trauma-related symptoms. So resources, since this is a fairly short talk and a very big topic, I really like the National Childhood Traumatic Stress Network. That's where some of my statistics come from. They have handouts, they have supports for school, they have supports for parents, they have different informational videos, handouts, all those sorts of things. So that's a really great resource. The American Academy of Child and Adolescent Psychiatry has an entire trauma and child abuse resource center on their website. Again, lots of good information for families and other community members that can be given out to help support folks in those situations. Grievingstudents.org is a website that was designed for schools, but the resources as far as there's YouTube videos on responses to trauma, what that might look like in school. And then there's different resources for support for parents, support for teachers, because when these kids are struggling, it certainly impacts all of the adults in their life as well. So making sure the adults are taking care of themselves is equally as important to taking care of the child directly in front of you. American Academy of Pediatrics has a lot of their own great resources. 2 in particular that I pulled out are healthychildren.org. They, in particular, have some handouts talking to children about disasters. So ways to approach that to make it not seem super scary, to talk about basic facts, talk about future safety, things like that. And then some really great resources for community members. Again, this is a resource that was designed for teachers, but it has some of the best descriptions on a non-clinical level of the cortisol response and kind of brain changes that might happen from trauma, normalizing some of the behaviors as far as academic decline, as far as acting out, as far as regression, and talking about kind of what is normal for a non-traumatized child to experience at a certain age and what might be seen in a traumatized child to experience at a certain age. These are some of the references that talked about the therapies and the medications for youth with post-traumatic stress disorder. And then this lists the ACEs. It's a PDF has the entire report. The National Traumatic Stress Network has community trauma tips. Again, this was designed for educators, but they generalize pretty well. And then those 2 handouts that I'd previously mentioned on sleep hygiene and breathing techniques for kids are on there as well. Since I work in kind of 2 different environments, kind of there could be 2 ways to reach out for more information or more support. So the website is a great resource for the Scanlan Center for School Mental Health Clinic. And then I hope many of you are already aware of the UI consult line. If there are patient-specific questions you have, maybe you're seeing a kid who's starting to endorse symptoms of PTSD, and you're either thinking about starting a medicine or have questions, certainly you can call the consult line. And then lots of ways to learn more about the resources at Scanlan Center as well. So with that, I will open it up for coffee to take questions.
Thank you, Dr. Elliott. That was very informative, and we already have some questions that have come in. Well, first was a comment. There are many therapists in Des Moines area that are trained in child-parent psychotherapy. So that's
Yay!
great. Thank you to the person who put that in the comments. Um, are there any modalities that are used for those who were exposed to drugs, specifically alcohol and marijuana, in utero and or growing as a child?
So there are no therapies that are designed specific for that. So many things, it's less diagnosis and cause specific as opposed to treating what the current presenting symptoms are. So if someone is just thinking about alcohol, for example, we'll often see kids that might have lower intellectual function, lower frustration tolerance, and more acting out behaviors. So rather than designing a therapy for alcohol exposure, they would work with a therapist on those target behaviors. Certainly when we know kids have had experience, whether it's alcohol, tobacco, cannabis, methamphetamine in utero, that often has an impact on medications. When I think about methamphetamine in particular, you think about a poor baby brain developing that has that methamphetamine and all of the receptors are getting used to that. Treating ADHD in particular can be tricky because we're often thinking about some kids that are really sensitive to our stimulant medications and some kids who need really high doses. So again, it's not specific to the exposure. It's looking at the child in front of you, the symptoms that they're having, and then finding either a medication or a therapist who is best equipped to treat their symptoms.
Okay, thank you. Can you repeat the number for or share the screen where you had the consult UI consult line number?
There you go.
All right, thank you. And I will also, we have a postcard with this number, so I will send that in the follow-up email as well. Another question, some of the psychiatrists are saying a diagnosis of ADHD, et cetera, is inappropriate when children have known trauma, example, in foster care due to neglect, and that diagnosis would not be appropriate.
That is a great question. So oftentimes in a snapshot, kind of figuring out what's the primary cause of what's going on and what might be sequela. So let's go back to some of the symptoms. Looking at PTSD. So let's see, ADHD, you struggle with memory, you struggle with concentration, you struggle with sitting still, so you might seem jumpy or fidgety in class. There's a ton of overlap with what might be trauma-related symptoms and what could be ADHD. Very similarly, thinking about some of the attachment-related disorders, kind of if no one taught you how to behave appropriately, or no one taught you correctly that hitting people is wrong. If you grow up in a household where you misbehave, you make somebody mad, you get hit, it's hard to then transition to a school setting where somebody makes you mad and you don't think it's okay to hit. So lots of different ways that this could play out. Certainly, if we can address the PTSD, the trauma with education about right and wrong, kind of very basic things like, depending on the age, some of those lines like hands are not for hitting. We want everybody to be safe, personal bubbles, whatever a level of teaching is appropriate for the child's development on those safety pieces, so that if they're acting impulsively in those ways, hopefully that could improve. Very often, PTSD and ADHD can co-occur. If you think about abuse that's happened, the likelihood that a parent had something like ADHD is also pretty likely, that the parent might still have had impulsive behaviors that related to a trauma occurring that then relates to the child. So while yes, there are symptoms occurring because of their PTSD, there could also very likely be symptoms happening because of ADHD. So when we do assessments, we kind of look at the big picture. If there are symptoms coming in that sound like a challenging behavior, broadly speaking, we'll send out a Vanderbilt to the current guardian and to the school teacher and kind of look at what symptoms are most interfering. in these cases, we have evidence for medications that do treat both with the alpha agonists. So we might start with something like clonidine or guanfacine first that might be helping both decrease that fight or flight response from the PTSD and helping decrease the hyperactivity and impulsivity from ADHD. So I certainly think they can co-occur, but it takes detailed history to know, okay, what symptoms are primarily coming from PTSD? Do they rule out ADHD, or could there also be an ADHD component? That would be really hard to do in a 15 or 30-minute primary care visit. So certainly some of those that are getting more complex would be appropriate to refer to psychiatry or psychology colleagues for further diagnosis. But the short answer, they can co-occur, but you want to diagnose carefully.
Okay, thank you. What would you suggest for a young child with autism and limited communication skills who have lost a loved one tragically?
So that is a challenging situation because they often have their rituals. If, let's say, it was a grandparent and they went to grandma's every house every Sunday for dinner, something like that, and now that routine is different. Or it's somebody that was part of their inner circle of people they trusted. One of the things that I like as a strategy in general for youth on the spectrum is social stories. So if they can find a book that's already written about a child who has lost a loved one and kind of read that on a regular basis, hopefully it has a conclusion where the child is certainly they're not going to be happy about the loss that they experienced, but they can manage it. Otherwise, often kind of a teacher or a guidance counselor, or if they have a behavioral therapist, could help put together that social story to explain kind of sometimes this is what happens. Somebody gets sick or has an accident, they pass away and they don't come back. Then the family could choose if they have a religious underpinning that they want to layer into that social story for how they talk about things at home, they certainly could. And then if the child has a behavioral therapist that they're working with, addressing any behaviors or emotions that come out from that loss. And then it's always helpful too for the kids that have limited communication, figuring out how to help them communicate that if they can. So they might not have current words in their communication app, pics, whatever they're using to convey loss, to convey missing a person. So making sure that you're working maybe with their speech therapist on having their communication device be able to help them appropriately communicate if they have the skills to do so.
Okay, thank you. There was a request to share the first couple, I think, slides that had the statistics. Maybe we can have that up for part of this discussion so they can see those. Okay, thank you.
And I'll flip to the second one here in a couple minutes, maybe after the next question.
Okay. And then there was a question about how young meds have been prescribed for ADHD.
So one of my favorite studies that exists is PATS, or preschool ADHD treatment study, that does go down as young as age 3. Typically, we try to look at behavior interventions first for kids that young, but some kids we see are so hyperactive and impulsive that they're running into traffic. Parents are trying to use the leashes and other things that might promote safety, but everything the parents are doing is being stymied by the level of hyperactivity and impulsivity of the child. So short-acting amphetamines were initially studied, as well as short-acting methylphenidate products. Insurance companies don't necessarily accept the PATS study when I'm trying to do prior authorizations. So treating the kids who are under 6 with medications can be challenging. But certainly there are indications for kids as young as 3 for use of stimulant medications for ADHD.
Okay, thank you. There was a question about access to the recording and slides. This session is recorded. I will send the link to our YouTube channel where we will have the recording available. And Dr. Elliott is providing a handout with resources and references that I'll share as well in the follow-up email. Okay. What modality do you find to be best for children that are consistently being re-traumatized um, by a parent who is repeatedly jailed? It's kind of a challenging.
That is a challenging question. I think what is most helpful is addressing it on multiple levels. So first and foremost, the child needs to know, or and hopefully the family, HHS, whoever can create a truly safe environment for the child. Because if life is unsafe, continuing, it's going to be hard to do therapy, to learn skills, things like that. So kind of hopefully they're working with whatever supports they have, maybe the other parent, grandparents, foster parents, to make sure that their home environment is as safe as possible. Also, the thing of like basic hierarchy of needs, kind of if you're not safe, you're not going to be able to work on any of the other skills that you need. And then it can come from a number of different angles depending on how the child is experiencing it. I know some folks who approach it with a grief and loss type therapy modality, that relationship you expect to have with your parent isn't there. So you kind of mourn that loss of the typical parent-child relationship. Other folks might use a dialectic behavior therapy or DBT approach with radical acceptance. I can't control what my parent does. I can't control that they come home and then they go back to jail, and they come home and they go back to jail. So learning both that radical acceptance as well as their own emotion regulation in context of that can be really important. For other kids who it's coming out as more disruptive behaviors, again, circling back to working with someone, whether it's a parent-child focused therapist, or for older kids, an individual therapist on kind of, okay, these are the behaviors we're seeing, tracing it back to like in the moments, are we identifying triggers and different ways we can cope in those moments?
Okay, thank you. And I do want to share, you just have some positive comments, some thank yous, and this information is very valuable and very, very helpful. So I wanted to share those. We'll try to get one more question. Do you think that complex PTSD should be a diagnosis added in the DSM?
That is a great question. As you may have picked up, I have my skepticism of some chapters of DSM and some of its rigidity. One thing, for example, I would put disruptive mood dysregulation disorder with the other disruptive behavior disorders. But that's just my personal take on things. I'm not as rigid with things like ADHD. If you've got 5 symptoms instead of 6 and it's impacting your life, I'm going to give you the diagnosis because you are struggling with that particular disorder. PTSD and complex PTSD is tricky. A lot of the symptoms that they talk about, going back to that slide, regarding that complex PTSD. The dysregulation, negative self-concept, disturbance in relationships. While the complex PTSD pulls those out as a separate diagnosis, they are encompassed in the 4 clusters of symptoms in our DSM PTSD. Looking at the research studies, often trauma-related symptom scores start higher in folks that have been given that designation of complex PTSD. But then both groups decrease to a similar baseline, whether it's a therapy modality study or a medication study. So there's somewhat of difficulty knowing kind of clinically what difference it makes. Kind of, is it something that's worth going through the process for APA to make that change when it's already more or less encompassed in their diagnosis? And also treatments don't necessarily change significantly. And also it's one of those things that could go back to invalidating somebody's experience. Somebody that had multiple severe experiences could have more severe or less severe symptoms than somebody that had one trauma. So making sure that the providers are able to treat patients that are presenting to them regardless of number, severity of traumas, number, severity of symptoms, I think is one area where differentiating PTSD from complex PTSD could be problematic. I certainly think Europe is being successful using that diagnosis. So I will not lose sleep if it were to be added. But I also think our current diagnoses encompasses it pretty well.
All right, thank you. So we've reached 1 o'clock, so we'll bring the session to a close.